Well, there is a new term that is called the silent hypoxia in COVID-19 patients. Well, the patient is having pretty much hypoxia, but that is only on pulse oximeter. There are no symptoms in the patient, no dyspnea, no shortness of breath. But when you check the SpO2 or a pulse oximeter, the SpO2 is less than 90%. Well, I have seen a lot of patients with the COVID-19 pneumonia. Well, they are not in distress, but when you check the SpO2, that is less than 90. So the concept behind that is in non-COVID-19 ARDS, in non-COVID-19 ARDS, what happens? The fluid accumulates in the lungs, in the alveoli. The fluid accumulation in the alveoli renders it stiff. So the lung is stiff. When the lung is stiff, it cannot distend on breathing. When it does not distend on breathing, what happens? The compliance is decreased. When the compliance is decreased, it cannot wash the CO2. So actually the CO2 retention is there. Whenever there is CO2 retention, we are talking about the non-COVID-19 ARDS. Whenever there is CO2 retention, it stimulates respiratory center and causes dyspnea, severe dyspnea. So it is actually the slight CO2 retention that causes activate the respiratory center. Now, what happened in the COVID-19 ARDS? Initially, the lung is not stiff. So if the lung is not stiff, there is no change in the compliance initially. When there is no change in the compliance, what happens? The CO2 can be washed out. If CO2 can be washed out, in spite of the severe hypoxia, CO2 can be washed out. If CO2 can be washed out, there is no dyspnea. So a person can have a sudden fall, sudden collapse due to the decreased oxygen to the brain and decreased oxygen to the heart. So it is said it causes ischemia, and when it causes ischemia, such as ischemic heart disease and cardiomyopathy, whatever it causes directly or through ischemia, that has got a poor prognosis. So that was the take-home message is we have to check the oxygen saturation of every patient, whether or not symptomatic, because nowadays they are hiding the history. So if the oxygen saturation is less than 90, the next step is to go for X-ray, chest X-ray, and you have to look for the typical pattern. Now what we do, we look only for consolidation. Consolidation is a thicker opacity. That is more whiteness. In GGOs, the opacity is not that much thick, that much condensed. So you have to look for the peripheries. We take that for as a skin fold shadow or fat shadow, but there is not the fat shadow. I have seen two patients, and there were opacity in both in the peripheries. In periphery, and the patient was not symptomatic. And when I checked the SpO2, that was 71%. And on CT, there were GGOs involving the peripheral zone. So we have to look carefully in the X-ray, the lateral zone, and we should not mess that lesion. That is actually the GGOs. So it will not actually the opacity the air bronchograms you see in the pneumonia. Rather, there is GGOs lying peripherally, and we know that in pulmonary embolism there is a peripheral involvement due to thrombosis. So that theory may be right that it causes thrombosis because the pattern is similar to that of pulmonary embolism.